In the management of non-ischemic heart disease, exercise testing has evolved from a tool for ischemia detection to a sophisticated method for functional phenotyping, hemodynamic unmasking, and prognostic stratification. For a clinician, the utility shifts toward evaluating the heart's integrated response to metabolic demand. In hypertrophic cardiomyopathy, exercise testing, particularly cardiopulmonary exercise testing or CPET, is essential for identifying patients at risk of heart failure progression rather than just sudden cardiac death. Prognostic thresholds. A peak oxygen consumption (PVO2) of less than 14 ml per kg per minute or less than 80% of the predicted is a robust predictor of adverse outcomes, including heart failure hospitalization and the need for transplant. Hemodynamic unmasking. Exercise stress echocardiography is used to detect latent left ventricular outflow tract obstruction. A gradient of 50 millimeters of mercury or more during or immediately after exercise is clinically significant in symptomatic patients with resting gradients below 30 millimeters of mercury. SCD risk stratification. The presence of abnormal blood pressure response, defined as failure to increase systolic blood pressure by 20 millimeters of mercury or more, or a drop in BP during exercise, remains a traditional risk marker, though its specificity is limited in older cohorts. Safety. Recent large-scale data, n equal to 7637, confirms that CPET is safe in HCM. Sustained ventricular arrhythmias occur in less than 2% of cases, even in high-risk patients. The 2025 ESC/EACTS guidelines have refined the role of stress testing in asymptomatic severe valvular disease to prevent irreversible ventricular damage. Aortic stenosis. The role is to unmask pseudo-asymptomatic status, symptoms during test, or drop in blood pressure below baseline. Mitral regurgitation. Unmask dynamic MR and exercise-induced pulmonary hypertension. Evaluate functional reserve in borderline LV function. Exercise-induced pulmonary artery systolic pressure more than 60 millimeters of mercury or unmasking of symptoms. Left ventricular and systolic dimension indexed to body surface area 20 millimeters per meter squared or more, or failure of ejection fraction to increase. Exercise testing is often the only way to diagnose heart failure with preserved ejection fraction when resting hemodynamics are normal. Invasive CPET combining gas exchange with right heart catheterization remains the definitive method to demonstrate exercise-induced elevation in pulmonary capillary wedge pressure above 25 millimeters of mercury. A high VE by VCO2 slope, that is equivalent to ventilatory efficiency, is often a more sensitive predictor of mortality in heart failure with preserved ejection fraction rather than peak VO2, that is peak oxygen consumption. VCO2 is the carbon dioxide production and VE is minute ventilation. In ATTR cardiac amyloidosis, patients typically exhibit a significantly lower PVO2 and a decoupling of the TAPC, that is tricuspid annular plane systolic excursion PASP ratio during effort, reflecting limited right ventricular contractile reserve compared to other hypertrophic phenotypes. PASP stands for pulmonary artery systolic pressure. Inherited arrhythmias, arrhythmogenic right ventricular cardiomyopathy, and catecholinergic polymorphic ventricular tachycardia. In this condition, exercise testing is primarily diagnostic and for risk assessment of effort-induced ventricular arrhythmias. In ARVC, exercise testing is recommended every 1 to 2 years to monitor for effort-induced ventricular arrhythmias, which typically present with left bundle branch block morphology. High-intensity exercise is strictly restricted as it accelerates desmosomal disruption and disease progression. Catecholinergic polymorphic ventricular tachycardia (CPVT). Exercise testing is the diagnostic cornerstone, revealing progressive ventricular ectopy starting with isolated PVCs and moving to bidirectional or polymorphic VT as the heart rate increases towards a specific threshold. Peak VO2 or the highest rate of oxygen consumption is the most objective measure of functional capacity. VE by VCO2 slope. Values 36 and above indicate ventilatory class 3 and above. Heart transplantation or left ventricular assist device implantation should be considered for subjects in ventilatory class 3 and 4 who do not respond to lower class after optimization of pharmacological interventions, implementation of an aerobic training program, and consideration of cardiac resynchronization therapy. Oxygen pulse, VO2 by heart rate, a surrogate for stroke volume. A plateau or decline during exercise suggests contractile failure or severe valvular or obstructive issues.